Welcome, everyone. We are happy to have you here. Well, Dr. Hanrong Cheng is from Shenzhen People's Hospital, Guangdong, China. We thank a lot to her because it's very late at her hometown now, and she agreed to this presentation. And I'm Dr. Özge Yılmaz from Türkiye. I'm a pediatrician, pediatric allergist, and Dr. Hanrong Cheng is a pediatrician, but working on sleep medicine mostly. Did I make any mistakes, Dr. Hanrong?
Oh, it's perfect.
Thanks a lot.
Thank you so much. Yeah, thank you so much for your introduction, and it's really my pleasure to be here. Today I would like to share of narcolepsy. So let's begin, okay? First, what is narcolepsy? Narcolepsy is a chronic neurological disorder that affects the brain's ability to control sleep-wake cycle. It is a lifelong neurological disorder, disrupts normal sleep-wake cycles. Since it is kind of rare sleep disorders with a prevalence of about 1 in 2,000 people. This often undiagnosed condition can significantly impact daily activities such as eating, working, and driving. I would like to explain a little more of narcolepsy. It is characterized primarily by excessive daytime sleepiness and possibly associated symptoms such as cataplexy, hypnagogic hallucinations, sleep paralysis, and disrupted nocturnal sleep. Currently, it is divided into 2 types. The type 1 is associated with CSF hypocretin deficiency and all the symptoms of cataplexy. And the type 2 is the objective findings of REM sleep disturbance in the absence of cataplexy. So REM sleep means that this is the initial of rapid eye movement. Is a stage of our sleep when we are dreaming. So this case is 15 years old adolescent with daytime sleepiness when he came to my sleep clinic. She has excessive daytime sleepiness for nearly 5 years. And has occasional snoring during sleep for more than 2 years. Occasional sleep paralysis, cataplexy, hypnagogic, and hypnopompic hallucinations. So since she has this kind of symptom and she cannot keep the normal school routines. Actually, both teachers and parents tend to believe that the child's behavior is due to her laziness or kind of psychological issues. And they wonder if the child might have depression. A little more of her history. In class, sleep came on her in waves, and there's no way she could stay awake. Her teachers called her lazy because she was always dozing off during class. Because of her symptom, of course, her learning efficiency is kind of low. So what is sleep paralysis? Sleep paralysis is sudden inability to move on falling asleep or on awakening. Episodes are generally brief and benign, but it can cause significant anxiety. The kids always scared of this kind of situation. Sleep paralysis may be accompanied by hypnagogic hallucinations. In terms of cataplexy, it happens almost once per month. The cataplexy is muscle weakness usually triggered by emotions such as joking, laughter, excitement, anger, brief duration, and mostly is bilateral, may affect any voluntary muscles like knees, leg, buckling, jaw sagging, head drooping, and postural collapse. But the consciousness usually maintained at the start. This is different from epilepsy. Until now, since from her medical history, we're thinking about OSA or narcolepsy. OSA and narcolepsy, they have the similar daytime symptom is the excessive daytime sleepiness. For the children, for these kids, for these adolescents, some occasional snoring. She has excessive daytime sleepiness. So we're thinking about these two diagnoses. So let's see what is OSA. By current criteria, OSA is defined by the number of respiratory events per hour on sleep testing. Patients with RDI or HI of only 5 or more can meet diagnostic criteria if they also have supportive symptoms or medical conditions associated with OSA, like snoring, weakness, apnea, fatigue, somnolence, mood, or cognitive disorder. So, let's see what narcolepsy type 1. We would like to say narcolepsy with cataplexy. That is type 1. So usually it has excessive daytime sleepiness occurring daily for 3 months or more. Has history of cataplexy confirmed when possible by a polysomnogram, a multiple sleep latency test, alternatively, low level of hypocretin in cerebral spinal fluid. And last one, which other causes of sleepiness are ruled out, such as, in this case, such as OSA, we should rule out OSA. So since maybe we are not so familiar with the multiple sleep latency test, we to explain a little more. So what is the multiple sleep latency test? Is 4 or 5 nap opportunities performed at 2-hour intervals, starting 1.5 to 3 hours after polysomnogram, the time the patient takes to fall asleep during each nap section, as well as the time to enter REM sleep from sleep onset are recorded. A nap section is terminated after 2 minutes if sleep does not occur, and a minimum of 6 hours sleep is required the night preceding the multiple sleep latency test. And the urine drug testing should be performed at the time of the multiple sleep latency test to identify drugs influencing sleep. So let's see these patients' test results. For the polysomnography, her AHI is 3.5. And her lowest oxygen saturation is 90%. For the kids at age 15, the HI, when the HI is less than 5, we define it as normal, quite normal, or just snoring. She has no apnea. So the multiple sleep latency test results shows that after 5 naps, 5 episodes of sleep occurred. The average sleep latency is 1.3 minutes. The REM sleep was present in all 5 naps. And here is the sleep architecture of the PSG. It shows her sleep latency is 6 minutes. REM latency is 7.5 minutes. Usually, the REM latency will not advance so early when we sleep, especially in adolescent. This patient, her polysomnogram documents 8.5 hours of sleep and shows reduced latency to REM sleep and normal sleep efficiency. AHI 3.1, we thought it is normal, and free of periodic limb movements. Her jog screen is negative. Here is snap of the multiple sleep latency test. It is very interesting, the sleep onset just in 1 minute after lights off. And we can show the REM sleep already show up. So here is the other architecture of the multiple sleep latency test. The rapid eye movement sleep occurred at all naps. Actually, when 2 or more episodes of REM sleep is consistent with narcolepsy, her average sleep latency is 1.3 minutes. Usually, according to the diagnosis criteria, mean sleep latency equal or less than minutes is short abnormal. So the other examination like head MRI, liver and kidney function, all of this examination is normal. Why we carry out this examination is we'd like to rule out the secondary narcolepsy. So this patient, our diagnosis is narcolepsy type 1. So to explain more detail of the ICSD-3 criteria for narcolepsy. For the narcolepsy type 1, the diagnostic criteria is here. Just show in this slide, the criteria A and B must be met. The A is the patient has daily period of irrepressible need to sleep or daytime lapses into sleep occurring for at least 3 months, and the presence of one or both of the following. The first is the cataplexy and a mean sleep latency of equal or less than 5 minutes and 2 or more slow REMs on sleep latency test. And a slow REM on the polysomnogram may replace one slow REM, and this case has the slow REM on the polysomnogram. The CSF hypocreatine 1 concentration is either equal or less than 110 pg per ml, or less than 1/3 of mean value obtained in normal subjects with the same standardized assay. We do not carry out CSF hypocretin 1 here, because according to the criteria, she already meet the narcolepsy type 1 criteria. And for the type 2, here is the diagnostic criteria. The first, the patient is the same, A and B is the same as type 1. The patient has daily period of irrepressible need to sleep or daytime lapses into sleep occurring for at least 3 months, and a mean sleep latency equal or less than 8 minutes or 2 or more SORAMs are found on a multiple sleep latency test. And it's the same, a SORAM on polysomnogram can replace one of the SORAM on the multiple sleep latency. Let's say if the patient has one SORAM on PSG, and the next day when we carry out the multiple sleep latency test, only saw one SORAM. So it can be, we can count into 2 SORAM. So it can meet the criteria, which we think the test results are positive. So for the type 1, usually the cataplexy is absent, and either CSF hypocretin 1 concentration has not been measured, or the concentration is either larger than 110 pg ml or larger than 1/3 of mean value obtained in normal subjects with the same standardized assay. The last point is the hyposomnolence or multiple sleep latency finding are not better explained by other causes, such as efficient sleep, obstructive sleep apnea, delayed sleep phase disorder, or the effect of medication of substances or other or their withdrawals. Yes, so let's come to the treatment. The treatment goals for the catalepsy is as follows. The one is through psychotherapy and behavioral therapy, as well as pharmacological treatment to reduce excessive daytime sleepiness, control cataplexy, and improve nocturnal sleep. Second is to help patients regain their daily and social functions as much as possible, to alleviate the symptoms of comorbid conditions as much as possible, and to reduce and avoid adverse reactions caused by medication intervention. So usually we emphasize on individual tailoring of therapy to improve alertness, productivity, and quality of life, and reduced risk of injury. The treatment will include both behavioral and pharmacologic science. Usually, since it's a lifelong disease, it requires regular follow-up and monitoring of symptoms. So here is the behavioral interventions. The first one is the most important, naps. For the narcolepsy, patient we should schedule 1 to 3 times of nap a day, aeroding to naps during the daytime. Adequate and regular sleep patterns is also important. Avoiding exacerbating factors such as sleep walk, alcohol, and etc. So all of these behavior interventions is necessary for the patient to maintain their daytime alertness. Yes, sometimes it's more important than the other treatment intervention. So the other option is treat the sleepiness with a stimulant. In here, usually we applied methylphenidate. Sorry, excuse me. Usually this one is effective for this patient. Actually, it's currently the most prescribed medication in the world for the treatment of this disease. Let's say for the kids, not for adults. This patient we applied 80 milligrams per day. But actually, it is not the first line recommended treatment medication, but it's available. It's available here for the patient. It's kind of embarrassing because it's not so much option to select what kind of medication for the kids. It's narrow. There's few options for the kids than the adults. So the next one is I would like to say is the pitolisant. Pitolisant is a selective histamine 3 receptor antagonist. It is marketed as Wakix and was approved by the FDA in 2019 for the treatment of EDS in adult patients with narcolepsy, and it was approved for the treatment of narcolepsy in adults with narcolepsy in 2020. But with the latest approval, Wakix is the first and only FDA-approved non-scheduled treatment option for EDS in children with narcolepsy. Actually, it's available already in China here. The patient can purchase pitolisant already here, just like the recent, just this several months. Yes. Other treatment options, yes, they have for suit, but not recommended for the kids. All of this is for adults. So let's skip it. Since it's a rare and lifelong disease, it needs a lot of communication. Usually the test results and a treatment plan are communicated to this patient, to the adolescents and her parents. And the sleep specialist monitor her progress, adjusting medications when necessary. Let's see the follow-up. Actually, these medications have a huge effect. The quality of her life is 100% better. The sleepiness 100% gone, but she had better concentration, more energy, and a sense of control of life. Not confusing. The diagnosis of catalepsy is it make a really difference for her life. She come back to high school, and actually now he's already in the college. As we know, her catapraxy is no go. Let's say the medication we are applying is not just for the EDS, but not for the catapraxy. But since it does not happen frequently, she can lead a normal life till now. The pitolisant just available this month, and it's more expensive than the medication she is taking now. So actually, we're thinking when he will follow up regularly. We are still thinking maybe pitolisant can apply when needed. It depends on her symptoms. Yes, actually, that is the case with diagnosis and treatment till now. I have more consideration. Can I move on or?
Yes, of course.
Oh, okay. So just some more consideration of the narcolepsy. Actually, narcolepsy is loss of hypocretin neurons result in all the symptoms we see. So the hypocretin is a neuropeptide of the lateral and posterior hypothalamus that exists the arousal systems of the brainstem, hypothalamus, as well as the cortex directly. People with narcolepsy has a severe loss of the hypocretin neurons, resulting in instability of the wake and sleep states. That's why. I would like to talk a little more show lumps. Show lumps can also be seen with untreated obstructive sleep apnea. OSA, we are familiar with OSA. So I don't think I need to explain more. So the sleepwalk disorder, abrupt discontinuation of RUM suppression medication. So that's why a sleep log should be kept for 1 week prior the study. Let's say prior the multiple sleep latency test, to demonstrate adequate sleep and a normal sleep pattern. So, in another, how to say that, to push the patient, because they write down the sleep diary, the sleep log. So kind of push them to keep adequate sleep and a normal sleep pattern. It's necessary before we carry out the multiple sleep latency test. And patients should be freed of medication that affect sleep for 2 weeks prior testing. The other key elements of the children's history I would like to communicate a little more is, in children, the presentation may include the reappearance of naps in a child that had discontinued napping, ADHD-like symptoms, behavioral problem or decreased performance at school. Misdiagnosis is quite common, really common for the kids. like the cataplexy or sleepiness may be mistaken for seizures, or a lack of energy may raise suspicion for depression or other medical disorders. Quite a lot. For children, for the kids may not be able to verbalize description of sleep paralysis or hypnagogic hallucinations. For the kids, it's kind of hard for them. And it will cause anxiety. It's kind of scared, you know, like the vivid dream, just to when we are awake, the vivid dream come, and then the loss of the muscle tone, you know that. Okay, so the typical presentation of cataplexy have been described in pediatric populations, such as the term protrusion, ptosis, jaw slackening, positive motor movements, and such presentations are generally not triggered by emotion. Not all of the cataplexy will fall down. No, just a little, and there just appear, you know, just the duration is not so long, and when we are talk to the kids or to the parents, it really takes time to get the detail of his medical history. In terms of the diagnostic issues, for the pediatric cataplexy, actually is extremely rare prior age 4. Cataplexy may occur early in the course of the disorder in children, even prior to excessive daytime sleepiness. Yeah. So I emphasize misdiagnosis is common. And the normative value for multiple sleep latency under age 6 has not been expressed till now. You know, the sleep latency under age 6 is kind of shorter than adults. So that's why the normative value. So let's say when he falls asleep during the multiple sleep latency test, when we found their sleep latency is less than 8 minutes, it's not suitable. It's not the normative value for the kids under age 6. Measurement of hypocretin in the cerebrospinal fluid may aid the diagnosis. We are not carrying it so routinely because it kind of hard for the parents and the kids to get their consent, informed consent sometimes, but anyway, we can make the diagnosis without hypocretin test. Yeah. So let's talk a little bit about the methylphenidate. There's a different dose. Usually, let's say the maximum dose is 60 milligrams daily. The pitolisant, in terms of the dose, is just starting at small dose. Let's say 8.9 milligram once daily. week 1 and increased to 17.8 milligram at week 2. Yes, we increase or decrease the dose. Just depends the kids' reaction. Depends on their symptoms. Pitolisant is not a stimulant, not scheduled. It can treat cataplexy and improve EDS, and that's why it was the first line option for the kids actually till now, as far as I know. Because it's a lifelong disease, it needs long-term management. So the regular follow-up and re-evaluations and monitor the potential side effects, the treatment failures, tolerance. Okay, when the kids follow up, every time we should take care of these aspects. So a lot of counseling should be carried out so every time, because we'll like the patient education. Actually the safety and jolting till now travel increase in risk of motor vehicle accidents when driving. Narcoleptic patients, 50% of narcoleptic patients occurred workplace accidents. 57% report losing job due to narcolepsy. When the patient is the type 1, let's say they have the catalepsy, we always should keep an eye on them when they are swimming, driving, or the other risky situations. Yes, here comes the conclusion. So narcolepsy is a disabling and prevalent disorder. The disorder can be reliably objectively diagnosed. The treatment is usually effective and improve EDS and quality of life. Actually, our understanding of narcolepsy is still on the way. It needs more. It needs more advancing our understanding of this narcolepsy, since it's not, it's associated a lot factors, but actually we don't know till now. And that's all. Thanks a lot.
Thanks a lot, Dr. Hanrong. That was Dr. Hanrong Cheng. That was a very nice presentation. I don't do sleep much, and I learned a lot. I have only one question. What are the side effects of the medications you prescribe? Side effects, unwanted effects of the drugs, medications.
Yeah, I know. Nausea.
Oh, perfect.
Nausea. It usually has nausea, or some kids not so much, but they do palpitation.
Palpitations, yes.
Yeah, palpitations. Yeah, some just one kids have this kind of complaint, but most of them are good. Yeah.
Perfect. You don't see much side effects.
Yes. Since we should adjust the dose,
We have 2 more questions. One, Dr. Johnny Xavier Morales Garcia. Do you consider monitoring with actigraphy for follow-up? Do you use actigraphy?
That's a great question. Actigraphy, we do not routinely use it. Just for the for the clinical study, some project. But according to the guideline, they don't recommend the actigraphy for the kids. But usually we use the sleep log.
Okay. Thank you. Sleep log. Okay. One more. Adaku Chukuma Chidiebere. Ada has asked, is the drug modafinil used in the treatment of narcolepsy?
Yes. Yeah, but only for the adults.
Okay. Thank you.
In my clinic, the oldest narcolepsy is like 50 years old.
50. No, okay.
Yeah, but his symptom is occurred at teens.
Okay.
Yeah.
Okay.
So
we have one more question from Dr. Nicole Baydon. Is there familial cases of narcolepsy? Familial. Are there familial narcolepsy?
That is a good question. The studies sometimes comes in family, but it's not a genetic not a genetic disorder. But the study till now shows it seems it runs kind of high more in familial than the other patients. Yes. Have some some association. Yes, but not so definitely.
Okay.
In my clinic, I have two families. Her mother and her daughter, and then her father and a son. Till now, like this, in these 3 years, there's 50 cases of narcolepsy diagnosis here. Only 2 lumps in family.
Okay. We don't have any other questions. Dr. Cheng. Nico says, thank you. Ada says, thank you. That was a very interesting case, especially for me. I don't do much sleep, so I really found it interesting. And the name was amazing. Dr. Garcia also says, thank you. Thanks a lot for joining. And we know that it's very late there. And thanks a lot for agreeing to do this presentation at that time. Thank you, Helen.
Thank you. Thank you. My pleasure.
I think we can close the session now. It was great to see everybody. Looking forward to our presentation next month. First Thursday next month. Okay. All right. See everyone. Thank you. Thanks, Dr. Chandrong.
Thank you. My pleasure.
Bye.
Bye.